Good morning. Welcome back for our last day of the 8-day course. We have got a very, very exciting pediatric program with a lot of debates and also a very good talks on vascular and head injury. So I will give the chairmanship again to Dr. George Jallo to take us through this very nice day. Thanks.
Great. No, thanks, Naren. I think it's a great program this morning. There, and I think we'll try to keep it as interactive as yesterday. I think all the speakers have no problems being interrupted during their talks, and I think there's no question that's a silly question, and hopefully I'm going to learn as much as you will this morning. And our first speaker is going to be Hal Rekate, probably needs no introduction, and the topic is going to be what is normal ICP in children, or something to that nature that he's going to educate us on.
Yeah, no challenge there. So when I was asked to do that, the problem is that what is normal intracranial pressure is not a thing that you can actually answer, except in generalities. What you really need to do is what's not normal intracranial pressure. For that, what is it that you have to treat? And it's not a static number. In every one of us, every minute of every day, we have changes in our intracranial pressure, especially during sleep, where you can have big time changes in your intracranial pressure. So a spinal tap, we get a range, and where the evidence comes from is in a deep past. I'm supposed to use this, okay? So I've been using, when I started out as a resident, an intern actually, I found at Case Western that almost everybody had ICP monitoring, usually with a Statham pressure transducer. So we've had a lot of experience, but rarely do you do normal people. I'm sure I've used ICP monitoring at least 1,000 times in at least 700 patients over the year. That includes head injuries when I was helping my partners who did aneurysm surgery and all of that. But the vast majority of what I do is CSF dynamics issues. So head injury, chronic daily headaches thought to be, the problem is that people would come with incapacitating headaches, and they would give a history, and somebody would assume that there was intracranial hypotension and there was a CSF leak because there was postural headaches, or because they woke up with crushing headaches in the morning that got a little better, they assumed it's due to pseudotumor or idiopathic intracranial hypertension, despite the absence of papilledema. And the absence of papilledema should not be considered a statement that everything is normal. It doesn't mean that you're being hurt. I'm of the don't assume anything unless you can verify it. If you've got to act on a piece of information that isn't solid, and you can find a way to make it solid, you can find a way to learn the actual numbers, I think it's irresponsible not to have made an attempt to find out what's real. So what I call real in my day-to-day work is that lying down, the intracranial pressure should be between 5 and 15 millimeters of mercury, and that means about 7 to 20 millimeters of water. And that's recumbent, and erect, it should be between -5 and +5 millimeters of mercury. Every time we stand up, the intracranial pressure goes down, and modestly negative intracranial pressure is the norm. But the question comes down to how high is too high and how low is too low. And it depends on what you're actually looking for, what you're actually trying to treat. The modified Dandy criteria which as far as I can see has really nothing to do with Walter Dandy except the name, and come upon after his death, considers the cutoff for treatment for intracranial hypertension of about 20 millimeters of mercury. There are lots of people who have chronically increased intracranial pressure and have ICPs in the 20s or above the 20s, particularly in sleep, and are asymptomatic. And unless there's a cost of it from a point of doing harm to the patient, there's no need to treat moderately increased intracranial pressure. So in a consensus among ophthalmology and neurology, any measurement of ICP by spinal tap that is over 200 millimeters of water is considered abnormal and justifies treatment of pseudotumor. So how does the body or nature or whatever control your intracranial pressure between those parameters? It's the Monroe-Keeley hypothesis. I put the hypothesis in large letters because it's not a doctrine at all. Doctrines are limited to political organizations and churches, and this is a misstatement because the Monroe in the United States, the Monroe Doctrine, which prevents Europeans from supposedly prevents Europeans from interfering in the affairs of the Western Hemisphere. That's what's known. So if it's the Monroe Doctrine, then it needs to be the Monroe-Kelly Doctrine. It's gotten so far that it's like trying to push the sea back. But I just think it's important to understand that. So the brain is there's three different compartments. One is of blood, which is arterial, venous, and capillary. One is brain extracellular fluid, and one is cerebrospinal fluid. And they all participate in the control of the intracranial pressure. And I think this is probably one of the, or if not the most important concepts in CSF at all. It's by Cutler, Page, and Galicic in 1968. And what it shows is that the formation of cerebrospinal fluid in each individual remains relatively constant and independent of intracranial pressure. And that for the absorption of cerebrospinal fluid, until you get to an opening pressure of 70 millimeters of 68 millimeters of water, which is about 5 millimeters of mercury, there's no absorption of cerebrospinal fluid. Now, since that topic, there are 7 or 8 different ways that CSF can be absorbed, and it's not always through the arachnoid granulations or arachnoid villi, because children under 2 don't have any. So there are lots of ways, and there's a lot that goes into it. But it looks when these are repeated over and over again, the system of formation versus absorption remains clear. So if you can see now, 112 millimeters of water is the sweet spot, right? And that's about 10 millimeters of mercury, or 9 or something. So that normal intracranial pressure is part of the controller is the formation and absorption. The other things are the CSF being able to distend the dural thecal sac, because while the skull is a fixed volume, the dural thecal sac in the lumbar region can expand and change its total volume that's of distribution. So what is the natural shunt? What is nature doing that looks like a shunt? Well, it's a cortical subarachnoid space, 2 dural venous sinus with an opening pressure of about 7 millimeters of mercury, a medium pressure valve. And that's an important thing because it has several things with it. First of all, the inflow and outflow are not separated. They're right next to each other. So you don't have a hydrostatic differential. whereas in shunts, the distal end is far away from the coming in end, and so that when you stand up, there's a hydrostatic pressure leading to negative intracranial pressure, which has become one of the hardest things to be able to manage. Now, part of the reason that it's the most difficult thing to manage, and by most of us is not thought of, is the fact that when you stand up and the intracranial pressure gets negative, that's by measurements at the right atrium, and you lie back down, the spinal fluid goes right back up again. So it's not ultimately lost. It can refill the tank instantaneously. Whereas when you drain by a shunt, it's gone forever. It's no longer available, and you have to make more spinal fluid to fill the tank. So just lying down isn't going to make the pressure completely normal unless you have a really effective way of preventing overdrainage. So it's a new world out there, and I have been studying it in a little group that I formed called the International Hydrocephalus Imaging Working Group, which brings together neurosurgeons, engineers, neuroradiologists, trying to use new techniques in MRI physiology to study absorption and production of CSF. And there's so many things, some of which have yet led to Nobel Prizes, like the aquaporin story, where the aquaporin 1 accelerates production of CSF, aquaporin 4 helps it to be cleared. There are also a number of other things, lymphatics, and all of these things which are brilliant, are proven to have some effect, and we have absolutely no idea how much of the CSF absorption and production is based on those things rather than the old ideas. So you can have transependymal flow. Transpeel flow it probably occurs, but it probably occurs only in the Virchow-Robin spaces, and that's where the CSF can go into the white matter, and it probably is higher in high pulse pressure times. So I had the privilege of working with the National Aeronautics and Space Administration for 3 years on their visual impairment and intracranial pressure program. And their mantra is Mars or bust. And it's a very, very complicated problem because the Earth and Mars have different orbits. And so they often are on the other side of the sun. So you've got a 9-year window. You have to, if it occurs at specific dates, the next time that you could go to Mars would be 9 years later. So they have to be ready for, I think, 2030 or 2028. One of the things that they found is that astronauts that have been, I know this is off topic, but I didn't have anything more to say about ICP, and I couldn't think of anything more to say, so I'll answer any questions. But the long-stay astronauts that have been in space for more than a few months develop folds in the retina. They develop oval rather than round eyes. They have trouble with vision, and they have special glasses to allow them to see. The longer you're out, the more this happens. And the older you are, it hasn't happened to any women that we know of, but it's cumulative. So if you've gone into space for 3 months at a time and it had been 4 times, that's a year in your eye point of view. And we don't understand it very well. The only way we can really understand it is to be able to measure intracranial pressure in space. And so far, that's a dream that has not been done. We talked for a year about using the PTEL, or the thing that Marianne and some of you have the opportunity to use for chronic intracranial pressure, but the flight surgeons are not willing to embed anything in an astronaut. what's the most serious complication of being an astronaut? Death. There have been a significant number of deaths in astronauts on taking off or even before they went. Right now, we don't have any way of getting, in the United States, and maybe private industry is going to fix this, but right now we have to pay the Russians to take our astronauts to the space station at an astronomical cost. And when they land in the middle of Asia. And it takes them at least 4 or 5 days to get to Landstuhl, where they can get a spinal tap done properly. So it's already too late by that time. So I'm somewhat concerned that we haven't made any progress in this. And this is the way the eye looks. It's being, and there are a couple of possibilities with this. When the astronaut program started, they were allowing 7% of carbon dioxide in the inspired. It's really hard to get rid of carbon dioxide in space. In a submarine, you can let it out into the ocean, but you can't do that in space. But now they demand that it has to be 3 or less, and the number of people that come back with it has been much less. Anyway, I just thought that was interesting. And we haven't solved it yet, and they can't go to Mars. And did you see the last thing about the twins? That one was they were identical twins, and one went to space and the other one stayed home. And their genetic material had changed in terms of of what's happening to them. I think that's the most frightening thing I can think of. I mean, are they bringing back the invasion of the body snatchers or something? So I finished early because I didn't have a lot to say. So are there any questions or comments?
Any questions? So how, the question I have is what's your algorithm when you have a child that has shunted hydrocephalus and presents with headaches that otherwise was asymptomatic prior, but now starting to develop headaches? How do you manage that child? Okay,
I'm relatively controversial. I don't manage them if it's not interfering with their life. If they can still go to school and still take Tylenol or anti-inflammatories, and they can live a normal life and go out and play, then I do nothing. I just counsel them. I think if they have a programmable valve, I first of all, that make sure that they have something to prevent siphoning in the valve system, because I think that's awful not to have something that creates that allows the very severely diminished intracranial pressure on there. So I did do just ICP monitors in them and classified the headache types. Almost all the headaches were from overdrainage and were helped by just changing the valve to a higher pressure valve. More recently, in patients who've had multiple shunt surgeries, I take the shunt out and replace an external ventricular drain, blow their ventricles up and do a third ventriculostomy if the ventricles get bigger. And 80% of those go home without a shunt. So if they're interfering with their life terribly, also all the patients that I take care of who are shunted are told that if their ventricles get bigger, they're going to have a third ventriculostomy and not a shunt revision. And that's not true in spina bifida. That's the only one that I don't. It's just too complicated. But I'm not getting that word across. But we did plan attempts to get in very complicated patients, a lot of them. And our old mentor Fred Epstein said, "Is the only thing that you need to know that the ventricles get bigger?" And I said, "Yes. If the ventricles get bigger at the time of shunt failure, it means there's no there's a failure of communication between the ventricles and the cortical subarachnoid space. And it is from the cortical subarachnoid space, however it is done, that spinal fluid is absorbed." So it works in 80% of the time.
So how do you blow up their ventricles? I mean, you put the EVD in.
Put an EVD in.
And how long does it? I mean, how long do you keep them in the hospital to be able to do that safely?
If you, they have, I schedule them for the removal and replacements with an EVD on one day, and for the definitive procedure, either putting back a shunt or doing a third ventriculostomy in day 3. And I started off with the drainage at 15 centimeters above the head level, so it stays high and doesn't go low. Get a scan in the morning. If they've tolerated that, then in the ICU, I turn it off, measure the intracranial pressure so that it doesn't go above the early 20s, and then get another scan.
I mean, so you tolerate a pressure of just up to 20? I mean, do you let it go higher than that, or?
I don't let their pulse go to 25. I mean, I think there's a clinical thing, but I usually have it open at 20. If it doesn't work at 20, I don't think it's going to work.
Harold, you commented on the importance of overdrainage and the management of the siphon effect. If you have a child which is asymptomatic and for any reason you get like an MRI every year, it doesn't have an anti-siphon device, and you see that the ventricles get smaller and smaller, would you go so far and do a prophylactic change of the valve to prevent the rising risk of shunt dysfunction, or wouldn't you touch the child if it's still asymptomatic?
I don't operate on asymptomatic people unless it's cancer or something. And the other thing is I don't do routine scans in asymptomatic patients.
So I mean, when you put a shunt in, you don't. Do you follow them?
3 months in a year.
And then
I don't follow them unless there's a problem.
After a year, you.
I follow them clinically.
Clinically, but no scans.
But no scans.
Okay. You should publish that so we don't have to.
George, you're of stature. You can make it stick just by yourself.
Really.
Someone else has to do it too. Too many people argue with me too often.
I mean, Jim, do you get scans?
Be
on
reasonable.
your
Do it my way. That's what I would say.
With shunts? Do you get routine scans when you see them in the office? No. Dennis, Crystal, no.
If they were very small when they had the shunt, like the post-hemorrhagic ventricular dilatation, we make an outcome scan at the age of 14 months or something, and then only a scan when they show up with problems.
What do you do in Italy? Do you scan them or?
No, absolutely not.
I was going to say I'm glad someone does because I do.
I do. I never scan them with a CT because this is harmful. We do MRIs.
I don't do CT, but when I see them once
Just to be clear, MRI. But if we put in only adjustable valves, and it makes no sense to have an adjustable valve without knowing how the ventricles develop, especially in the early age. We don't do follow-ups after 10 years. But when we start to follow up a baby, we look at the ventricles, if we can, at least every year.
Why? Why?
It's peace of mind for me. I mean, I do it once a year. I do a fast MRI once a year.
And you would use the information to do something different. There's.
I mean, Hans is saying yes because he's got a programmable valve, right?
Yes, because
all of my patients have programmable valve.
We can adjust the resistance of the valve if the ventricles start to get smaller. It's easy. It's 10 seconds.
Of course, it's easy, but it's not necessary. And they're going to come back the next day and don't like it.
I agree. It's quite a number of children where you never have to change the valve again. But there is a couple of children where the ventricles get smaller and they need a higher resistance as they grow.
I don't ever believe that that's true.
Well,
I need to get my
So I
thing
guess
on
in
here.
South Florida and in Germany, we do the same thing, so.
Thank you very much, Dr. Rekate. I just wanted to ask Dr. Rekate and anyone in the audience, sorry that Dr. Jula couldn't make it today. Dr. Jula's study, I thought, was saying that the ICP, normal ICP, is usually quite low. And that's number one. Anyone knows more on Dr. Marianne Jula's work. Number two is that I think from her work and what we always thought that if you stand up, the ICP goes negative in the head. At that time, does the ventricles collapse around the shunt? So they are the two questions that I wanted to ask. So first, is anyone quite familiar with Dr. Euler's work? And second,
Yeah.
if the ICP is
She
negative standing?
has three orders of magnitude. I mean, three after the decimal point. She has three more. I mean, that's not. The numbers are taken too literally and we all get different. It's the way we measure the type of monitor you have. But I read all of those things, and the pressures are. First of all, the pressures that she has, that she said these are normal patients because they just took a little brain tumor out, and that's the reason. But then she saw it at 1 week and 4 weeks, and the pressures were low. It's hard for me to imagine that the craniotomy didn't have some effect on that, because we do have lots and lots of data that would distill that. What else? What was the other question?
Second question is that when we stand up, the intracranial pressure is negative. And what happens to the ventricular size when
Okay, what's coming out? Why does it go negative? Why?
the CSF goes down into the theca?
From where?
From the ventricles?
Only from the ventricles?
Ventricles and
There's no pressure differential between the ventricles and the cortical subarachnoid space. So you're draining both at the same pressure, both the ventricles and the cortical subarachnoid space. So there's no change in the size of the ventricles.
Okay, thank you. Cheers, thank you, that's very interesting.
I can't get my thumb drive off, so.
And Hal, my last question is lumbar punctures in children.
Yeah.
And your neurologist says the opening pressure is elevated. What do you do with that number? And you present to the neurologist or pediatrician just with headaches, no papilledema, but they do 1, maybe 2 lumbar punctures, and they're telling you the pressures are elevated. I mean, what do you make of that once they refer them to you?
I look for evidence of intracranial pressure problems, like in a small child, like scalloping of the skull, like the possibility of an empty cella. The eyes can show things, but again, for just headaches, I would never operate on such a person without knowing a clear cut, and I usually put a ICP monitor in if I'm being pushed. And the parents are going crazy, and they're worried that this is a problem, but there's no papilledema. Just probably to calm the waters, I'd probably put them in overnight.
ICP monitor. I mean, there's some people that would take them to the operating room, put an EVD in, measure the pressure. If it's elevated in the operating room, then they would shunt them. What's your thought on that?
Well, that's emotionally, it's an operation, and I know how human nature is, pretty much, and I think that your chance of putting a shunt in that patient is extremely high, and you've already committed to putting something in the middle of his brain, and so the next thing, it's only a shunt. It's only a shunt. It's not a shunt. It's a sentence. If you can possibly, I'm going to talk later about avoiding shunts and how important it is to avoid shunts, because it's something you have to live with forever. So be careful.
Okay, great. Thank you so much.